the only way to start your day.
At 7 minutes after 7, we are happy that you are tuned in to Kenya's biggest conversation, The Situation Room. Wherever you are across the globe, Asante Sana. We broadcast from the Standard Group Center on Mombasa Road in Nairobi. We are across the country on Spice FM and KTN. We are across the region on KTN and other live streams as well on YouTube and Facebook and X and TikTok and Radio Garden. We are everywhere. So whether you're in Papua New Guinea or in Equatorial Guinea, or what's the other Guinea? Guinea-Bissau. Karibu sana. We appreciate your presence. Now, all those people can benefit from one thing, and that's a lifestyle app. And it's called?
Loop. So you can imagine all the different things that you need to do, and you essentially are looping them. That's what we're looking at. It's circular. Is the loop circular? But don't worry. Just know that the ends meet. All right? So essentially everything that you need to do, you can get it in one place. There's a Loop app, and you go to your Google Play Store or your Apple App Store, download the app. Once you do that, what does it allow you to do after you've registered? All your payments, you pay your utility bills, you move money from your bank account to your mobile wallet, or even moving money from your mobile wallet back to your bank account. You can do so many things once you're in on this app. You can, like I said, pay your bills. You can also get an overdraft of up to 100,000 shillings or a personal loan up to 3 million shillings. And you can do all of that from the comfort of the app on your mobile phone. It really is changing the way in which you look at life, that you don't have to take a step to go anywhere, but you can do everything from one place. Why think when you can loop?
You know the thing that does, and that's the thing, because you are saving so much time of, walking to brick and mortar here, talking to somebody there and all, and you're just doing all those things from your fingertip, it then frees up your mind to start thinking and dreaming. And you can turn those dreams into reality immediately. I'm thinking I'd like to do this and the other. And you can interact and engage on Loop. Imagine running a business, and then you also have access to all those people who are on the Loop app, who are your potential customers, and you can interact with on the same app, and you're banking using the same app, and you're getting credit using the same app. That's why they say it's not an app, it's a lifestyle. It is a lifestyle. Our guest is in the studio. She is the Cabinet Secretary for Health, Dr. Debora Barasa. Good morning, Dr. Ari.
Good morning, Eric. Good morning, Du.
Karibu sana. That's the hot seat of the Situation Room. It's good to have you here.
Thank you. Thank you for having me.
I can see you are well. You're healthy. We are also well.
Asante.
As far as to the best of our knowledge, so far, we're healthy.
Touched the forehead for now.
We are healthy. I want to give you two pieces of information. One will be a proverb, and the other one is, because I know you interact with very many people, even in your office and staff, and sometimes your staff would like to call out in the field and talk to people, or you want to communicate with one another. And there's one thing that usually happens. The moment when you are right in the middle of a very important call, credit naisha. Or you're at that moment when you are online and you are researching, you're consuming content, maybe you're playing back a video, data in Aisha. And then now you have to go and look at how to top up. So you go to your M-Pesa, you find the credit balance in M-Pesa is low, so I have now to go to my Loop so I can get from Loop to M-Pesa to buy. Safaricom has looked at that and seen there are very many people who are actually just buying credit regularly in a month. And if we look at what they're using the credit for, calling, data, texting, how about we just say, come up with an all-in-one package that then says, if you spend this much, you have access to data, you have access to calling time, minutes, that's voice, and you have access to SMS, text. And we can also add something on top, free WhatsApp.
Yes, there you go.
So it's called the all-in-one. And with all-in-one, say for 2,000 shillings, you have 1,000 minutes of talk time, you have 2,000 SMSs, you have 17 GB of data, you have free WhatsApp. I mean, if you do that, those things of that you needed to call somebody because you've just been called and there's an emergency in school and you need to talk to because your children or you don't have airtime at that time when you needed it, forget about it. So now you live your life, peace of mind, because you've done 2,000 shillings a month. And they say the way to do it is *544#. And then it brings in a suite of options. You go for the Go Monthly one. When you go to Go Monthly, it tells you which all-in-one package would you like. You select the all-in-one package, and that's it. That sounds good, doesn't it?
Yeah, it does. Brilliant.
Sorts out people's lives. It's about your life. Mental health is important, as you will tell us. And when you have peace of mind, your mental health is good.
Indeed.
Now, our colleague Siti Muga would have loved to be here, but he's away. He usually goes to one African country and he mines proverbs from that country, and then he brings proverbs from that country. One proverb a day. And when we have a guest in the studio, we tell the guest, listen to the proverb, give us your own interpretation of that proverb, and tell us what you think. This week, Siti said, let's go to Libya. Libya, as you know, is called the State of Libya. It is a unitary republic under a provisional government. So since that thing that happened and Muammar Gaddafi was done the thing that he was done, they've not had a stable government. They've been having a provisional government. And the chairman of the Presidential Council is called Mohammed Al-Menfi. The vice chairman is Musa Al-Koni. They have a prime minister called Abdul Hamid. And they have a speaker of the house called Aquila Saleh Issa. And the legislature is the House of Representatives. Of course, the capital is Tripoli. And there are those that say that even Benghazi has a claim to it. But we go with the official one, which is Tripoli. Now, the proverb for today from Libya is a very simple and straightforward one. If you listen to it, I'm sure you'll get it immediately. He howled before going mad. He howled before going mad.
Okay. Well, I think for me, it sounds like where there's smoke, there's fire. So, yeah, we start looking at the signs, before now, something comes up. And I believe that, indeed, even during this time, coming from the medical background, we have seen a lot of people suffer, a lot of people die, especially the needy, the vulnerable, the low-income earners. And in terms of health insurance, most Kenyans don't have a health insurance. And so for me, this is really a time for us, seeing that it is part of the government's agenda to implement universal health coverage and to ensure that all Kenyans have affordable, accessible, quality care. So before he gets mad, let's do what? Let us ensure that things are settled, or before, things get out of hand, before we have high mortality, before we have people dying, people having illnesses, and donors may be pulling out, there's Hamas, so there's shunting of funds to other countries. And as Kenya, even as Africa, we need to have sustainable solutions in terms of financing, and especially for health financing. We need to stand on our feet, we need to be stable, we need to be self-sufficient, and we need to have sustainable solutions. And so this actually resonates with the discussion today on UHC.
The country is howling. We do something before it goes mad. Waziri, the issue of universal access to health has been a conversation in this country for years. Attempts have been made. In the previous administration, there was an attempt to roll out UHC. There was a pilot that was done. There was a strategy that was being developed, stopped. The Kenya Kwanza administration came in, said, let's relook at how this thing is going to be worked on, came up with laws, bills were taken to parliament, they were passed. October last year, President Ruto says, now we are launching UHC. Because we have the laws in place, now it's implementation phase. We have been in that conversation since October. Oh, Mara, it's July. Mara, it is September. Now we are coming into October. Where are we in the rollout of UHC? Like, finally.
Thank you for that question. So maybe I should start with what UHC is all about, so that all Kenyans understand we need to walk the journey with everyone. We need to own it as Kenyans and see what is in it for us. What are the benefits? And when you look at the model for universal health coverage, it's all about affordable, accessible, quality care. At the community health level, we have the community health promoters. They are at grassroots level. They are the ones who interact with the community. They are important in terms of prevention and promotion of health within the community. They are able to identify pregnant mothers so that they can start antenatal clinics and then ultimately prevent maternal death. Again, they are able to identify children with malnutrition, those who have not been immunized, so that we don't have high death among the children. Again, diabetes, hypertension, and other health education, including emerging and re-emerging infections within the community. So now they are the first contact. So let's take a patient's journey. The first place the patient visits is the primary health care, our dispensaries and our health centers. And previously, as you know, there were challenges in terms of health products, human resource supporting these primary care networks or primary health centers. And so patients would move right to Kenyatta Hospital, you know, or other high hospitals, you know, overloading them and overburdening them. And so we looked at strengthening this area and in terms of products and in terms of human resource, And what the model also looks into is that after having the health insurance, just like the Linda Mama, a claim is sent and the resources come back to the facility. And so the facility is able to capacitate itself. So you saw Linda Mama with the kind of funds they were receiving, they were able to capacitate the primary health care. They were telling me, we bought equipments, we were able to have increase some of the support staff, etc. So how about NHIF, or how about the universal health coverage? What we are doing, as you are talking about the loop, this is also a cycle, a vicious cycle where we are having resources back at primary care level to capacitate it. Now, let's say this patient is referred. Maybe they have a complication, maybe kidney disease, cancer. So they are referred to the higher levels of care. So at this level of care, you know, such conditions are called conditions that have catastrophic expenditure. When you're started on dialysis or you have cancer, what happens? People sell land, they sell their cows, they sell everything. And the challenge with that is that you deplete your resources. And I always remember the story of a man I saw in Kenyatta National Hospital who was on dialysis. But thank God, at one time he had a health insurance. But during my study, I saw how he took his title deed and he took some of the properties and he was giving it to his wife. And what that showed me is that he's giving her so that maybe they can secure a loan or they can get finances for him to go through dialysis. And that was heartbreaking. Actually, when I saw the man the first time, I thought he would die because he had difficulty breathing, but he went for dialysis and he was stable. Now, a few months later, and even as I continued in my Masters of Medicine, internal medicine, I still saw the man. So I was wondering, how much has he sold in order to access these services? And ultimately, suppose he dies, or suppose he's depleted of his funds, what happens? He won't afford dialysis. He will die.
That's it.
And then he leaves his wife as a widow, the children as orphans, and they have nothing. And that is the reality. So when you go to a private facility, even right now, if it's an ICU case, you're being told 200,000 deposit. Where can we get that money? So at that level 4 to 6 is where people are having catastrophic expenditure. And so, and previously, when you look at the NHIF model, it was only incorporating the employed, so 4 million, more than 4 million households, and then the poor and vulnerable were also could also access. But now we are saying all Kenyans need to access care. You never know when a disease will be knocking at your door. You never know when your relative will be needing the care. And how do we have that health financing? We cannot always depend on donors. It's all about us bringing to the table, contributing as Kenyans based on our financial capacity or our financial muscle. And so that is the model. And you can see previously NHIF, anyone earning 500,000 and above would only pay 1% of their salary. And yet a person who earned 30,000 and below, 5%. You see? But with this model, that was called a regressive model. The progressive model is about your capacity. So it's a percentage of your capacity. So level 4 to 6, we want accessible, also affordable, quality care. And this is through contributions from all Kenyans.
Right.
Yeah.
Waziri, all those things that you've said,
Yes.
completely true. And everybody in the country agrees
Yes.
that there is need to look at how we can all access healthcare better, more affordably. And that it doesn't cost us, and that we have the best quality that we can get.
Yes.
So far, yes. Government says, let's roll out this plan, and this plan is the one that's going to solve the issues. And where Kenyans have been is, okay, but how? And when? So there's been a conversation about when the UHC will roll out. What's the difference between the NHIF and SHA? And we've had the chairman of SHA, we've had Director Dr. Matende Chero and others from the ministry coming here to explain what SHA is, the advisors of government in the ministry, the PSs have been here. So we had the conversation about Chief SHA. It's about now the implementation where people are going to see this is the actual difference. And so the question comes back again. When are we starting the rollout, proper rollout? We know the CHPs were hired, they've been in the communities. The other rollout of this UHC, when does it begin?
All right. So the rollout is anticipated for 1st of October. So that is the rollout. And maybe to just inform you, what we are doing currently is ensure that all the facilities are capacitated. So we will start with the ones that have been offering NHIF because they already have systems in place. So we will incorporate the platform, the digital platform, where the claims will be, requested and also processed, as well as the registration platform. So this
are these new platforms?
Yes, these are new platforms. Yes, so it's a whole topic in itself. It's about digital superhighway. So what we are starting with is called a minimum viable product for claim processing. Yeah, but ultimately what we are looking into and what the plan with the consortium is about building a digital superhighway, where we are having, various, like the community health promoters information incorporated there, the KEMSA, the health products, supply chain is monitored, tracking of products, again, the issue of human resources to ensure that all facilities are well capacitated and the doctors are also licensed, again, to look at the health facilities and the health service delivery that is there, and issues of infectious disease surveillance and other surveillance that would cause health security, among others. So it will be a comprehensive a platform where it's, again, interoperable, so you can see patients. The same records are in Nairobi, they are in Coast, they are in Nyanza, etc. So that there's interoperability, but again, there is protection. So now coming to rollout. Rollout is about preparation. Launching is on the 1st of November. Now we are rolling out. We are ensuring that the devices are in place. We are ensuring that the health workers have been trained. We are ensuring that even the claims people, anyone who's going to be involved in matters of health is trained, and the devices are there. The systems have been incorporated in preparation. Again, the transitioning. We are transitioning the NHIF clients. So currently we have more than 4 million households, and so we intend to transfer that. So that's around 10 million to 12 million. Again, we have the indigents, or the poor and vulnerable, as identified by the Labor and Social Protection Ministry. Again, those will incorporate, and equally with the children. So through the education, and those ones, we can link up and see what family, because part of it is you register as a parent, and then you will put your dependents thereafter. So again, we'll get a good number. So we believe that before the launching, this is the rollout where we are now taking the steps towards the launching. We believe that we'll have enough Kenyans enrolled or registered before now the actual launching.
Okay, Dr. Barasa, so what happens for still seeking care? Because we understand that obviously there will be a migration, right, from one system into another. But what happens for folks who are seeking care in the interim? I really have to go present myself to hospital and be treated while this is being rolled out 1st October, 1st November. What happens? We also know that folks are currently registering and there's already hiccups here and there. What happens to ensure that there is no stoppage of provision of healthcare for folks who have previously been registered and paid up on NHIF?
Wow, that's brilliant. And actually, that's where we are. We are at the transition. And you are very right. Even coming from the medical background, I'm always thinking that man going for dialysis, that woman who wants to deliver, who's almost delivering. We need to ensure that the transition, and that is the sensitive area that we are ensuring. And part of it, what we're doing is communication. We have materials on transition for NHIF clients. We are communicating through the media platform, using the community health promoters, using the Ngao, our colleagues, and what we are encouraging Kenyans, please, the services are ongoing, so you can access the services even as we migrate. And then for NHIF, what we are doing is that there is an SMS that will probe you, informing you that we are transferring you. So there is no way, there's absolutely no way that an NHIF client should stay at home. They should just visit a facility and they will be informed. So the services will be continuous. They will continue even as we transition. And that is an area that we are keeping an eye on and monitoring to ensure that our the NHIF clients are accessing our services.
The health provider
Yes.
in these facilities, does he know this? Do they know this? Do they know that we will still accept NHIF members for the month of October?
Yes.
And do they know how they'll get paid? Because everybody knows, so NHIF is coming to an end and we have a new entity that's going to come in. We are at the point of transitioning. In this transition period, what communication have you had with the health providers, with the service providers, the facilities, the hospitals, to be guaranteed that their money will be paid? You see, they've had issues earlier this year where they were saying NHIF has not paid us for very many months. There are very many arrears. How have you dealt with that?
Yes, indeed. We are looking into that issue of supporting or paying the NHIF debt that is present. So that is something that we are looking into as a ministry. And what we are saying is services need to continue. Healthcare services need to continue. For health, it's a sensitive matter. It's about life and death, unfortunately. So we need to ensure that there's continuity of services. We have engaged partners. We have engaged the private organization, faith-based organizations, the ministry. We are, as I said, yesterday was the last day when we had the national trainer of trainers. Will cascade into the regional to county level and down to facility level. And so we anticipate in the next 2 weeks, the information should have reached all facilities. And we also expect that the system will be incorporated in the next 2 weeks. And then after that, now we will be able to ensure that everyone is trained and there's a seamless flow before now the launching on the 1st of November.
Several institutions or associations. One is the Rural Health Providers Association, RUPA. The other one, the Private Health Providers Association. and also now looking at the Faith-Based Providers Association. Those ones had issues earlier in the year, where they had even said, we are no longer accepting NHIF because of the arrears. As we sit here today, Waziri, can you say that none of these associations would complain of arrears with NHIF, that they are comfortable with NHIF as of this morning?
That is, yes, thank you for that question. We had a lot of challenges with NHIF. And you remember the corruption, even the audit that was done quite recently, and also coming from the medical background, you see, there is one hospital in particular where you remember that the knee it was a very small hospital, and they had more than 50 knee replacement surgeries in a day, which is impossible. And it was even higher than Kenyatta National Hospital. So there were challenges in terms of service delivery. They were misquoted and overpriced in terms of products, in terms of patients. You could hear that the patient is in Coast, the patient again is in Nairobi, and the claim is being sent. Again, there were issues with them. There were many issues, from facility to provider to patient level and up to NHIF. And I believe those were the challenges. And through the digital platform, we are trying to minimize corruption. So at patient level, what are we saying? We are using biometrics. And these biometrics are actually, matched to those of NRB to ensure that the patients are the same. Why is that? Because they were using different fingerprints. So you could have the manager of the facility is using his fingerprints for various patients within, you see? So that was a point of corruption. But in this case, we are saying that before you are seen in a facility, we take your biometrics or you get an OTP. Again, what happens is there is a message that will always come if you went for, any surgical procedure. So if it's not the truth, then you can always follow up on that. Now we come to the health workers. Again, we had multiple claims. You're hearing a surgeon is in various regions. But in this case, we are saying once you log in, you cannot log in to another region. So the healthcare providers, and then we ensure that if you are a practicing clinician, then you need to be registered so that we are having the best or offering quality to our patients. Again, at facility level, as we said, the capacity, the health service delivery within a facility, we are able to map out and know what can they do and what can't they do. So you see, we are fighting corruption gradually as we move up. And equally what we said about the supply chain, tracking medicine and ensure that it reaches the last mile. And I know one of the questions Kenyans are asking is about tenders and open tenders. One of the things that will be done is that at KEMSA level, we'll be able to see. Maybe this manufacturer is selling Panadol at 8,000, this other one at 100, this 50, 1 shilling and so on. So we can see it's transparent, it's visible to each one of us how the products are. And then we'll be able to monitor quality so that whoever is providing for us is accountable, is held accountable. So this system will fight corruptions in multiple ways. And that is why I would like to encourage even the faith-based organization, the private institutions. We are working gradually to ensure that we are fighting corruption. And one of the greatest achievements that will come that is coming, we are starting with the minimum viable product, but gradually we'll improve it, is the digital platform.
Let's take a break. We'll continue this conversation shortly. Our guest this morning is Dr. Debora Barasa. She's the Cabinet Secretary for Health. We are talking about the rollout of UHC, and also we'll delve into her vision and other plans for the health docket. Keep it here at 25 to 8.
This is the Situation Room, the only way to start your day.